Hello, this is Lichaa, interventional cardiovascular specialist, going over the balloon puncture access technique. This technique applies in the arterial and venous systems, both if the operator is coming from an antegrade or retrograde directions, depending on the goals of the procedure. The idea behind it is when the operator needs to get access into a scarred sclerotic segment to place a sheath, either because the distance to the destination or to the target area is not being reached from the initial access, or when the operator needs a bigger size sheath to be placed in order to perform further interventional procedures. So the figure that you see illustrates the difficulty when the needle goes into a very sclerotic segment and the access wire is trying to travel through the interluminal space, and basically the operator is not able to get access to place a sheath. So at this point, when the operator is across the access site from an initial primary access with a wire, and again, the reason why the operator cannot proceed with the intervention from that initial access is either limitations related to distance with the length of the interventional equipment that would not be compatible, or with the fact that the distal or proximal access site is too small to introduce large caliber devices. The idea applies here of getting a balloon from the access site to the secondary access, inflating the balloon, and puncturing this balloon under fluoroscopic guidance to get the access wire to loop into the shaft of the balloon. And at this point, the balloon is advanced forward to the destination or further along the vessel to allow for this access wire to travel through the intraluminal space. And at which point the balloon is deflated from the initial access site, which is distal or proximal depending on what the operator is doing, and the balloon is removed, but the access wire remains in the lumen to allow for the operator to place a sheath in this vessel. We're going to illustrate this in a venous case. This is a case of a chronic post-thrombotic syndrome where the access of the popliteal vein was challenged by the fact that there was not enough tibial inflow for the continued patency of the popliteal vein, and the decision was made to access the tibial vein to open up that posterior tibial inflow into the popliteal vein. And subsequently, of course, there was a need for iliac vein stenting, and of course this is not doable from a tibial vein access, so the common femoral vein needed to be accessed, but we found difficulties in getting access to this diseased vein, which was ballooned from the tibial vein access. So in this case, after multiple attempts at accessing the common femoral vein, which was again very diseased under ultrasound guidance, failed, we decided to inflate a balloon from a tibial vein and place a hemostat on the skin to allow for adequate positioning of the needle. And then the balloon was punctured under fluoroscopic guidance. You can see here when it's a manual feel when the balloon actually gives, and it's a fluoroscopic finding obviously when the needle hits the balloon, at which point in a supportive 018 wire is advanced within the lumen of the balloon itself and looped within that lumen, and this will allow the entire balloon to be advanced forward into the iliac vein from the tibial vein access in order to gain some ground for the placement of a sheath into the common femoral vein and iliac vein stenting.